Well, we're heading to Tokyo now, where I'm delighted to be joined by Professor Ruby Pawankar, who is President of the Asia-Pacific Association of Allergy, Asthma and Clinical Immunology and Head of Allergy Division, Department of Paediatrics at Nippon Medical School in Tokyo in Japan. Ruby, it is very good to see you. Thank you for joining me.
Thank you very much, David. Indeed, it's a pleasure.
So just on a very personal note, I know you moved to Japan some 30 years ago. Perhaps you could just explain to us about CRSwNP in Japan, just kind of how big the problem is.
Well, if you look at the prevalence of CRS with nasal polyps in the current scenario, it's about 0.25% in the population. But historically, if you look at the evolution of what CRS with nasal polyps and CRS itself was over the last 30 years, it is interesting to note, and as you might have also heard from others, my colleague speakers also, that Japan always had very neutrophilic nasal polyps. So we never had any eosinophilic nasal polyps 30 years back. And in fact, for several years, it continued to be mainly neutrophilic in nature, and in fact was often associated with diffuse panbronchiolitis. And in fact, macrolides were in fact a very good treatment for this subset of chronic rhinosinusitis with nasal polyps. Around the same time, there was a lot of eosinophilic nasal polyps in Europe and in the United States, which wasn't seen here. Over the last 10 years or so, there has been a drastic change of the pattern or the endotype and phenotype of nasal polyps or chronic rhinosinusitis with nasal polyps, moving more towards eosinophilic type of nasal polyps.
So that's very interesting. Just before we go to the mechanisms that underlie severe uncontrolled CRSwNP, just tell me, how big is the problem of uncontrolled or severe uncontrolled CRSwNP in Japan?
So of all the CRS with nasal polyps, approximately 10% of them are uncontrolled. And then of the uncontrolled, about 30% are actually severe.
Okay, so as far as I understood from what you said, that you saw a major shift there from sort of neutrophilic to eosinophilic mechanisms. Tell me, what do you think, or what do people believe underlies severe uncontrolled CRSwNP in Japan? What are the immune mechanisms driving the recurrent disease?
First of all, it's unknown why this change has actually occurred. Whether this is due to diet, changes in the diet, or changes in the epigenetics, or changes in the way we use the treatments like antibiotics, those kind of mechanisms are not clear why we've had the shift from a neutrophilic to a more eosinophilic type of CRS with NP. However, the basic mechanisms, what you see in CRS with NP, that is eosinophilic or eosinophilic chronic rhinosinusitis with nasal polyps, you find a Th2 type of inflammation, which is different from the neutrophilic type, which is more of a Th17 type of inflammation and interferon gamma. There is a kind of Th2 type of inflammation. These patients who have chronic rhinosinusitis with nasal polyps of the eosinophilic type often have also comorbid conditions like asthma or aspirin-associated respiratory disease. And so they often tend to have a lot of recurrence.
Okay, so I suppose the next question then is what sort of Japanese patients, what sort of profile will then benefit from these new biologicals for CRSwNP?
Now, when we talk about the biologics, there are 3 different biologics that are available internationally. Of course, omalizumab or anti-IgE. Then you have dupilumab, which is against the anti-IL-4 receptor alpha chain, which actually is in fact impacts both IL-4 and IL-13 pathways. And of course, you have anti-IL-5. So there are 3 different monoclonal antibodies that are, or biologics that are available internationally. But in Japan, the only one that is actually approved by the Ministry of Health and Labor and Welfare is dupilumab.
So perhaps the next question then that leads nicely from this is what profile of Japanese patients will benefit from the new biologicals for CRSwNP?
So the type of patients that would benefit from biologics are those patients who do not respond to oral corticosteroids, that do not respond to surgery and have to undergo repeated surgery, and their symptoms are not well controlled. Unlike the non-ECRS type that respond very well to surgery. So these group of patients who have additional comorbidities like asthma and NSAIDs and have to undergo recurrent surgeries really would improve with the biologics. Now we have 3 different biologics internationally: omalizumab, that is anti-IgE, we have anti-IL-5, and then we have dupilumab, which is anti-IL-4 receptor alpha antibody against the receptor alpha chain of IL-4, which also acts against IL-32 because of the common receptor sharing between IL-4 and IL-13. So in Japan, the only biologic that is approved by the Ministry of Health is dupilumab. And dupilumab has shown really good effects because it actually is very effective in large nasal polyps and in fact prevents the need for repeated surgery. And those patients who tend to have the tendency to have repeated surgery, those who have that severe TH2 type of inflammation, those who have large number of eosinophils, those who have more ethmoid involvement, ethmoid sinus involvement, and those who have high levels of serum periostin, which is again a marker of recurrent nasal polyps. So these group of patients will have been shown to improve or do very well with dupilumab. So using a biologic as we move towards biologics, I think this works as a very, very important treatment strategy for those patients who will otherwise have to undergo repeated surgery and yet not get relief.
So what's the scenario in the rest of Asia then, Professor?
We find similar findings in China, in Thailand, and across South Asia, that there are mostly neutrophilic type of polyps. But that is again evolving to have a change towards an eosinophilic type of nasal polyps or recurrent nasal polyps or ECRS. So this is something that the Asia-Pacific Association of Allergy, Asthma and Clinical Immunology, APAAACI, is now conducting a survey in all the Asian countries, looking at the types of the phenotypes and endotypes of chronic rhinosinusitis with nasal polyps, the treatment strategies, including the biologics, and we are in the process of developing a consensus and a guideline that would be valuable for the introduction of novel therapies in this region.
Well, thank you very much indeed. It's been really informative and wonderful to talk to you. That is Professor Ruby Pawankar.
Thank you, David. It was a pleasure.
Well, that's it for this edition of EUFOREA TV Breaking News. Many thanks to my guests, to Professor Shigeru Fueda and Professor Ruby Pawankar for their extremely informative interviews on the use of biologicals in the treatment of CRSwNP in Japan. Now you can find more information about EUFOREA and also register for the EUFOREA meetings on the euphorea.eu website, where you can also sign up to receive the latest news via email. You can also follow us on Twitter. The address is @EUFOREA. But that's it for this show. See you soon, and thank you for watching.